Okay, told you guys I would finish up the lecture on fluids and electrolytes, and let's see what we can do here. I think this is about where we stopped. Let's talk about acidosis and alkalosis for a bit. I think I mentioned this yesterday. But basically, acidosis is when the pH falls below 7.35. Alkalosis is when the pH goes up above 7.45. And I think the point that that makes is just how tight our pH control is at all times. That's really important for all of our body systems, all of our chemical reactions, all of our enzymes to work, and so forth. CO2 is probably our biggest controller of pH, especially in the short run, because we know that the PCO2 very quickly converts to carbonic acid. Most of the carbonic acid dissociates into CO2 and bicarb, and then the CO2 can be expelled. So therefore, really the PCO2 is the most important factor affecting the pH in the body tissues. And remember that as the PCO2 goes up, the pH goes down, because CO2 is an acid, basically. And so when PCO2 goes up, pH goes down, as illustrated there, and vice versa. When CO2 levels rise, hydrogen and bicarb ions are released and the pH goes down. If you're at the alveoli and you're ventilating, in other words, you're moving air in and out, then the CO2 can easily diffuse out into the alveoli and go and escape into the atmosphere. Hydrogen and bicarbonate in the alveolar capillaries drop as you blow off that CO2, and the pH will rise. Obviously, if you ventilate too much, if you hyperventilate, you can actually make yourself alkalotic by blowing off too much acid. This little diagram here is one that you should really understand because you'll be using this a lot when you're trying to figure out the problems of acid-base. So think about this. At homeostasis, PCO2 is between 40 and 45. I think we use the number of 40 as normal. pH between 7.35 and 7.45, you can just call it 7.40. That's a perfectly normal pH for blood. If the PCO2 rises, now what would make the PCO2 rise? Hypoventilation, not breathing enough, not blowing off enough PCO2. So if the PCO2 rises, the pH falls, as illustrated down here, and acidosis develops. So this person, when the pH goes down, the PCO2 goes up, and the patient becomes acidotic. Just the opposite of that, if the PCO2 falls, if they're breathing too much, they're blowing off the PCO2, the PCO2 falls, and the pH rises, and alkalosis develops. So remember that pH, PCO2 are inversely related. Don't ever forget that, because that's kind of the one thing you can always go back to help you figure out these acid-base problems. Now, we have more than that, because we can also gain and lose hydrogen ions. And you remember that hydrogen can be secreted in the kidney, and that's very true. So over a period of time, over usually days, we can fix up an acidosis by simply secreting extra H ions, acid ions, in the urine. But just remember that that's a lot slower than the PCO2 is. Where do we get those hydrogen ions? We get them at the digestive tract whenever we eat acidy things. We also create acid through cellular metabolic activities. And I think that's all happening all the time, and you need to realize that. That's why we need to breathe all the time, to get rid of the extra PCO2, which also contributes to the acid-base problems as well. Where do we get rid of hydrogen? Well, we do it in the kidneys, in the urine, and also in the lungs via the PCO2 deal. We have to neutralize that acid, otherwise our body turns acid and everything gets damaged and we die, basically. And I think just important to remember that acid is always being produced by normal metabolic activity. It can be temporarily neutralized by a series of buffer systems that we have in our body. Buffer systems can help neutralize acid and neutralize bicarb, neutralize base, but they're limited in ability and they can be overwhelmed very quickly. You still have to keep breathing to keep getting rid of that stuff. What is a buffer system? Well, from the chemist's point of view, it's a combination of a weak acid and the anion that's released by its dissociation. So therefore it functions as sort of as a weak base. And we have these molecules of these weak acids all the time in our system. The three major buffer systems that we have are the protein buffer system, the carbonic acid bicarbonate buffer system, and the phosphate buffer system. Now, I don't think you need to worry too much about these. This is the big one, of course, the carbonic acid bicarbonate buffer system that we've been talking about. Proteins, though, do help to regulate pH, and because they can interact with the other buffer systems and help remove extra acid or remove extra base if need be. Just remember that buffer systems are limited and they only can provide a temporary solution. We've got to, because they don't really get rid of any hydrogen ions, they don't get rid of any base ions, they just kind of tie them up for a while to take them out of solution to help with the pH. I just think it's important that you know that buffer systems are really good, but they're only good in the short run. And if you have something like hypoventilation, not breathing enough, these buffer systems get overwhelmed in a matter of seconds sometimes. But they're very important for the fine-tuning of pH in our bodies. So we've got to, in order to really fix the problems, if we've got too much hydrogen, for example, we've got to get rid of it. We've got to get that hydrogen out of our body, and the way we do that is either through the tied up with CO2 and then removal of the CO2 at the lungs and removing it from the body fluids through secretion at the kidney. Remember that our kidney can secrete hydrogen. And when we do that, we usually exchange it for something, usually potassium, as it's trying to get out through the kidney. I think I've beat this respiratory compensation to death, and let's just say that we will all alter the rate at which we breathe if we change our minute ventilation. And what we're really talking about, of course, is not just our ventilation at the mouth, but the ventilation down in the alveoli. Alveolar ventilation rate is really what's important here, because that you don't get rid of any CO2. With air, you just bring them to your trachea and put back out into the dead space there, remember. So, I think basically this is saying the same thing I've said before. I'm going to stop it at that, and I'm going to then move on to how the kidney takes care of acid, and it does by secreting. Now remember, we do filtration, we do reabsorption, and we do secretion. So secretion is usually an active system. It's an active transport system to get rid of stuff we don't want. It happens in pretty much the different regions of the tubules in the PCT and in the DCT, as well as in the collecting systems. So a lot of the kidney works on hydrogen, but it still works very slow compared to our breathing. Renal responses to acidosis. When we're acidotic, we have too much hydrogen, we secrete it, we tie as much as we can up in the buffers, we breathe off as much through the CO2, and we reabsorb as much bicarb. Because obviously, if you have too much hydrogen in your system, one way to neutralize it is to pick up some sodium bicarb. The sodium bicarb will tie up the extra hydrogen. And I mentioned the other day, when you have a cardiac arrest and somebody quits breathing and they become very, very acidotic very quickly, one of the first drugs that they're given in a cardiac resuscitation is bicarb, sodium bicarb, in order to neutralize things and bring their acidosis back up to near normal. Because at that point, until you get the acidosis corrected, it's really hard to get the heart beating again, to make CPR work, to make defibrillation work, and all that other stuff. So acidosis is really a big problem in those cases. I think I've said enough about this. I'm going to just move along there. Let's talk about the different types of acid-base problems. The first one we'll talk about is respiratory acidosis. Now, by definition, respiratory acidosis is because you're not breathing enough. You're not blowing off enough CO2. The CO2 builds up, you become acidotic. Remember, PCO2 goes up, pH goes down, and enough said. The primary cause is hypoventilation down here. The primary sign of it is the pH is low, and when you look at the lab report, the blood gases, the PCO2 is going to be high. So you have hypercapnia, that's high PCO2. You have low pH. Remember, they work in opposite directions. The next one is respiratory alkalosis. And the primary sign of that, of course, is a high pH because they're alkalotic, and it's due to hypocapnia. In other words, you've blown off too much CO2. Usually you're hyperventilating, and teenage girls will say, "Mom, I'm going to breathe so much I'm going to pass out," and they do, and that's okay, because as soon as they pass out, they'll start breathing normally again and correct themselves. There are patients who have terrible problems with anxiety, and they just can't slow down their breathing. And one of the things you can do for that is have them breathe into a bag, and then instead of blowing off all that CO2, they're actually breathing back in the CO2, and that can correct the problem. Metabolic acidosis is the third one. Metabolic acidosis means you're producing a whole bunch of acids, either because you're taking too much in or your kidneys aren't working. If your kidneys aren't working, you can't get rid of hydrogen, you will become acidotic. So most patients with renal failure become acidotic. It's called the renal acidosis. There are other patients who become metabolically acidotic because they've lost so much bicarb there as well. Two other kinds of metabolic acidosis that I know you've heard about. One is called lactic acidosis. That's usually from exercising way too much. Your muscles burn and sting, and you build up lactic acid from the anaerobic metabolism that takes over in your extremities when they've used up all the oxygen. And then you become lactic acidotic. That can usually be fixed pretty easily simply by making sure the patient has enough IV fluid or has enough fluid, and they quit exercising so much. That will usually repair itself. Ketoacidosis is another problem. We see it in diabetics. Diabetic ketoacidosis, for example. These are patients whose sugars are way out of control. Sometimes their blood sugar will be up to 1,600 or close to 2,000. And their ketones in their urine. We did a dipstick on the urine the other day, and if they have too much ketones, those ketone bodies actually become acids, and they are acids, and that can make you ketoacidotic. So these patients will often come in very, very sick with very low pHs, and that's a big problem that's got to be fixed right away to get that under control. Now, obviously, everything isn't cut and dry. There are combinations of respiratory and metabolic acidosis that occur. And I'm just going to kind of mention this one here because respiratory and metabolic acidosis. Just know that acidosis is by far more common than alkalosis, especially in a hospital setting. It's usually caused by low amount of ventilation. And if they're not ventilating enough, not only do they have buildup of their CO2, but they don't have enough oxygen then. So then they can't think, and if they can't think and they pass out, then they don't breathe either. So it becomes very self-generating. Obviously, when you're doing those things, you're not generating enough oxygen, and therefore you're also building up lactic acidosis, because building up lactic acid, because once again you don't have the oxygen to convert your metabolism to aerobic metabolism as opposed to anaerobic metabolism. So suddenly, if you're not breathing, you're just fermenting to make two ATPs out of a molecule of sugar instead of 36 if you're doing it aerobically. So this is probably the most severe and the most difficult to fix. Obviously the patient needs to breathe, he needs to ventilate more, which, remember, ventilation just means moving air in and out in order to get rid of that CO2. And they also need oxygen so they can convert from anaerobic metabolism to aerobic metabolism. Metabolic alkalosis is one we haven't talked about yet. It can be caused by an elevated bicarb level. Sometimes patients will take too much Mylanta or too much soda bicarb if they have like an acid stomach and they're just pouring that stuff down. That can actually give them a metabolic alkalosis. They eventually get a low hydrogen level. And if your hydrogen ion, your acid level, is low, you become alkalotic. There was something happened there that I have no idea what it was. It wasn't good. And I'm sitting here in this lab, and let me see what I can do to figure out where we are here. Come on, baby. All right. Go back to slideshow. Okay, here we go, maybe. We'll see. So anyway, we go back to that thing we looked at before, that kind of the graph that you can work your way through. This is another format of it, but look at this one here. If you're trying to figure out whether a patient is acidotic or alkalotic, one thing you can do is check a pH, and that's done by doing a blood gas. Remember that blood gases are done on arterial blood, an arterial stick, either at the radial artery or up here in the arm at the brachial artery. But you got to have arterial blood to really get this down right. So, if you're acidotic and you check the PCO2. Because if you know they're acidotic, then what you got to determine is whether they're respiratory acidosis or whether they're metabolic acidosis. And the way you're going to tell that is by their PCO2. So you check their PCO2. If their PCO2 is high, then that's the reason they're acidotic. They have a respiratory acidosis. The most common cause we've talked about several times is hypoventilation. If then you want to check and evaluate it a little bit further, check their HCO3, their bicarb. If it's increased, then that's going to tell you that they have a chronic compensated respiratory acidosis. And the biggest examples of these are the old geezers who smoke too much and they don't have enough lung function and they're breathing like hell, but they still can't move enough air. Emphysema, asthma creates those kind of problems. And as a result of that, their bicarb starts climbing. Normal, remember, is 24, so if it's up to 28, it's climbing. If it's normal, then they don't have a metabolic component to it. It takes a while to develop a metabolic component, and so then they have acute respiratory acidosis, either due to respiratory failure, they've had a stroke or something for which in which case they're not breathing, or a pneumothorax, in which case they can't breathe. Okay, so that's a respiratory acidosis, but what if you have that acidotic patient and you did a PCO2 and it was not increased? In other words, it's not respiratory in basis, because you can just look at a PCO2 and you instantly know whether they're breathing enough or not, and that tells you instantly whether it's a respiratory problem. If it's not increased, if their PCO2 is not increased, then you know it's a metabolic acidosis. And then you can look one more level and look at their PCO2, and because first thing's going to happen when you get acidotic, your respiratory system is going to try to compensate for that. So if you are metabolically acidotic, you're going to try to compensate for that with a respiratory alkalosis. In other words, you're going to start breathing fast, okay? And so the way you check that is by checking the PCO2 level. And if indeed it's normal, it's acute. If it's decreased, it's a chronic metabolic problem, and the respiratory system is reducing the amount of acidosis, and that's good. There's a thing called anion gap, which I always never did understand very well, and always made me think of Gary Puckett and the Union Gap. I don't know, it was a band from back in the 60s. Anyway, but the anion gap is something that can tell you how much bicarb they've gotten rid of, and if they've lost a bunch of bicarb, their anion gap will be normal. If they've regenerated a whole bunch of organic acids, like in the lactic acidosis, ketoacidosis, or chronic renal failure, you'll have an increased anion gap. All right, so enough for that side. Let's go over here and talk about alkalosis a little bit, although remember, alkalosis is much more rare than acidosis. The first thing you do if you have somebody that's alkalemic, if they have a pH above 7.45, you check their PCO2. And obviously, if it's increased, they have a metabolic acidosis, bicarb will be elevated, and it could be caused by a metabolic problem, either by vomiting or losing a bunch of gastric acid from one reason or another. You can do that with an NG tube, by the way. You can suck out a whole lot of acid out of somebody's stomach with an NG tube and lean towards this problem here. If it's a respiratory alkalosis, you know that their PCO2 is going to be down. Why? Because they're breathing too much, they're blowing off too much acid, and that makes them respiratorily alkalotic. Primary cause is hyperventilation then. You can check the PCO2 to see where they stand, and that'll tell you whether it's either acute or chronic. Remember, chronic always means that the body has tried really hard to compensate for it by dealing through the kidney, because remember, the kidney is kind of the slow mechanism for correcting these issues. Okay, now, yesterday or the day before, I filmed another little vignette for you guys, and it's called, it's the clinical conference. And I do that to try to reinforce these four things we just talked about. So it's a number of cases, there's some x-rays, and I think you'll find it kind of interesting, but it kind of goes into trying to figure out what's wrong with some folks based on their numbers, and they're all basically acid-base issues. Well, there's one or two that are different, but so much for that. Okay. It's been a lovely morning here in the lab at 7 o'clock. Y'all have a great Tuesday.